I just actually said this past week, regional interdependence is real, right? And especially with our low back pain patients, just because that they're experiencing that pain doesn't mean that the low back is the problem. And the SFMA is really that tool to help guide us to locate what is causing the stress in this individual system. Is it that thoracic spine? Is it the ankle, the hip, whatever it may be? Now, Kyle, another kind of statistic I've been reading recently is those individuals who have experienced low back pain, there tends to be a 60 to 85%, depending on the source, where they're going to have a recurrent episode. And I wondered if you could maybe just kind of share how that's our problem really as healthcare professionals.
Yeah, no, unfortunately, and this is not news to anybody, back pain is a problem. It's challenging to treat. And if you look at the data, really even the epidemiology folks that typically in the past would write about, you have a back pain episode, take a walk, maybe take some Tylenol, keep up your activities, and you'll be okay. Like that's the message, and that's the message that's out there. But the reality is that it just doesn't work, and it's not true. And they're coming around to that. A Lancet, so a major medical journal, top 5 journal in the world series from a couple of years ago. If you read into it, they're really saying, listen, back pain is a waxing and waning condition that once you have it, it's yours, right? So in terms of recurrence, obviously we want to get people moving better. There's different little predictors of recurrence that are in there, and they're multidimensional. There's psychosocial pieces, there's muscle impairments, and there's movement impairments that are part of that. And I would think just if we can do anything, and I've just spent a lot of time with musculoskeletal health and in our military and large groups, if we could do anything to change things overnight, it would be to make a passionate plea for people to utilize standardized discharge tools. So some sort of competency in something at discharge, right? Rather than just, hey, I'm feeling better, things are looking good, and they disappear on you, right? We've got tools we'd recommend. I've got tools we've researched. I could consume the hour talking about that, but some competent discharge tool, simple as single leg balance. Can they touch their toes? Can they cover an anterior reach? Obviously, we'd recommend the functional movement screen and the full Y balance test. We've got tons of data on those. But if people were getting discharged in some standardized way in musculoskeletal health, I think we'd see these numbers go down a lot, including low back pain. And it's a way to create that relationship. You know, I think at the end of the day, you want a relationship with a patient, and the reality of musculoskeletal health is it just doesn't go away, right? I mean, we like to think we discharge someone and they're better, and they are better, but something else is going to happen if they're active and they're engaging, and that's okay. I want the first knock on the door or phone call before my patient starts a new anything. Like, hey, Kyle, what do you think of this? Can I go do this program? Should I do this? Should I avoid this? What can I do? I want to be that person's musculoskeletal healthcare provider for a long term. I think that's a good goal. It's not disingenuous. Doesn't mean I'm coming, bringing them in and doing manipulation once a week. That's not what we're talking about. So again, discharge tools, an annual kind of approach, if you will, semi-annual kind of approach, a dentistry model. That kind of approach is what we would advocate. We have all those tools and research to support it. So.